I'd first of all like to thank the President, Dr. Nanya Kara, Secretary, and the committee of the Candy Society of Medicine. It's a real pleasure to be back in Candy. I'm a Candy girl, and so I grew up in these halls when I was a medical student, so it's nice to see some very familiar faces in the audience as well. So thank you all for coming. So first of all, can everyone hear me? Yeah? Okay, great. So the topic of our talk today is chronic diarrhea, an approach to the investigation and management of non-infectious colitides. And I'm going to focus my talk on some key objectives. It's a wide topic, so I've narrowed it down to identifying the non-infectious causes of chronic diarrhea. We're going to look at the initial approach in assessment and evaluation of this diarrhea, and then we're going to move on to the meat of the program, which is identifying the different subtypes of inflammatory colitis, and through a series of case scenarios, I'm going to talk about the varying diagnostic and treatment strategies we can take. So chronic diarrhea is really common as a symptom, right? So we all see patients with chronic diarrhea, whether in primary care or general practice or in our hospital. But it's really important when we see these patients to establish that they truly have chronic diarrhea. Chronic diarrhea, the official definition, is a persistent alteration of the stool consistency from the norm of loose stools, which is Bristol stool chart 5 to 7, for more than 3 times a day for at least 4 weeks of duration. So I often get patients coming to clinic saying that they have chronic diarrhea, but they're passing these very solid Bristol stool chart 1 stools 2 or 3 times a day. That's not diarrhea. So before you start a full bunch of investigations, costly investigations, make sure you get a good history. We have various ways of stratifying or dividing up chronic diarrhea when we're approaching our investigation and management of these patients. For the purposes of today's talk, I'm going to focus on osmotic and non-osmotic diarrhea. The osmotic diarrhea is really what we call diet-related or substrate-induced diarrhea. This is usually due to malabsorption of carbohydrates, so lactose intolerance is one common reason to have osmotic diarrhea. The patients tend to have a small volume of stool, less than 200 mils, but then once they start having the diarrhea, if they stop eating for about 24 to 48 hours, then the diarrheal symptoms resolve. Another common reason for this osmotic diarrhea is the presence of taking various laxatives and also common medications that are used. The non-osmotic diarrhea has more sinister causes, and I'll talk about this in a bit more detail later. These diarrheas used to be more voluminous, usually more than 200 mils, and they don't necessarily stop with fasting. So these are just some examples of the types of medications that can cause chronic diarrhea. This is a very varied audience here, so you know that cardiology medications like digoxin, we all learn in medical school how this can cause diarrhea, but then there are other more newer drugs such as the androstenedione receptor blockers like olmesartan, which can cause a sprue-like condition, and then these fibric acid agents are also commonly associated with diarrhea. The CNS medications, particularly the SSRIs, selective serotonin reuptake inhibitors like fluoxetine, anticholinergics have been linked to profuse watery diarrhea such as microscopic colitis, and all of us are familiar with patients on metformin who complain of diarrheal symptoms. Thyroxine, as we all know, can also lead to diarrhea, as can some of the newer GLP-1 receptor agonists, which are used for the treatment of diabetes and also obesity. Many of our patients are on proton pump inhibitors. These commonly cause diarrheal symptoms, particularly in the elderly. There was a big scare some years ago when a paper was published saying that patients who are on proton pump inhibitors, particularly elderly patients, were more susceptible to Clostridium difficile infection, but the numbers needed to harm is about 500 to 600. So the main symptom of diarrhea that these patients experience is more of a loose bowel movement. But again, it's something to think about. And a lot of medications do, like laxatives, do contain sorbitol, which is irritant to many people's colons and can cause a type of secretory diarrhea. The 5-amino-salicylic acid agents, such as mesalamine, are commonly used to treat ulcerative colitis, but in a small percentage of people, about 10%, they can conversely cause an increase in diarrheal symptoms. And when you discontinue the mesalamine, the diarrhea gets better. Non-steroidal anti-inflammatory drugs commonly cause an NSAID-induced colitis, where patients will complain of diarrheal symptoms, and sometimes prolonged use of NSAIDs can actually trigger a flare of ulcerative colitis. And then there are all these other dietary and supplements that people take nowadays, which very often contain sorbitol to make it taste sweeter, and these can lead to chronic diarrheal symptoms. We are familiar with a number of antibiotics like the amoxicillins, the cephalosporins, the neomycins, which can lead to diarrheal disease. And anyone who has treated an oncology patient or had an oncology patient as a relative knows that a lot of these antineoplastic agents can lead to diarrhea. So, okay, next slide. So moving on to chronic non-osmotic diarrhea. Infection is obviously a key cause for this, but I'm not going to talk about this in more detail because of the time restraints, but we do want to exclude infection in individuals who present with this symptom. The bulk of my talk today is going to focus on inflammatory causes of diarrhea, such as ulcerative colitis, Crohn's, and microscopic colitis. Remember that malignancy, colorectal cancer, often causes a bloody chronic diarrhea. But in addition to that, there are precancerous lesions, such as tubular villus adenomas of the colon, these polyps which can cause a profuse watery diarrhea. And then you have gut lymphomas and also hormone-secreting tumors such as carcinoids and vasoactive intestinal polypeptide tumors, which can also lead to a chronic diarrheal symptom. Ischemic colitis, we tend to see that more with elderly patients or athletes like marathon runners. Individuals who have undergone radiotherapy, particularly to the abdomen, can develop radiation colitis, which primarily due to fibrosis of the colon. And then steatorrhea is something that many patients have, where they have report these very fatty, pale stools, which, if you go by the textbook, are difficult to flush. This can be due to maldigestion, which is due to insufficiency of pancreatic enzymes, which prevent the absorption of nutrients into the mucosal cells of the intestine, or it could be due to malabsorption, such as in Whipple's disease or in Crohn's disease, where mucosal inflammation prevents the intestinal mucosa from absorbing nutrients. You could also have surgeries which lead to short bowel syndrome or small intestinal bacterial overgrowth, which can lead to diarrheal disease. So this is just an overview of what you need to think about when you're seeing a patient with diarrhea and what you need to sort of mentally be checking off when you're taking the history as to what are these risk factors for these potential causes. So I can't stress enough how important a good history is, and that's something I really learned at Peravenia, and I'm very grateful for that. And then in addition, based on the history, we can obviously want to exclude infection with stool studies, and then we can consider some of these more expensive, first non-invasive tests like CT imaging, or more invasive tests like endoscopic evaluation with either a sigmoidoscopy or a colonoscopy. I don't routinely do expensive tests like gut hormones unless there is a real suggestion clinically that the patient might be having that. But I always try to keep in mind about those red flag symptoms. So is the patient before me anemic? Have they had weight loss? Are they clinically unwell? Is there a family history of colon cancer, precancerous polyps, or inflammatory bowel disease? And these are patients who probably need more invasive investigations sooner rather than later. So just to summarize these key history elements, first make sure that the person has true diarrhea. Is it bloody, suggestive of colonic disease? Is it watery or steatorial, suggestive of more small intestinal involvement? Is this patient having nocturnal symptoms? So nocturnal symptoms are another red flag sign. This is something that they can't control. So this is, again, something that we need to be concerned about. And are they on certain medications or taking certain foods that could be triggering their symptoms? Infection, we need to think about travel, contact history, and then their social history for HIV. And then I talked briefly about how prior surgery, like gastric surgery, so patients who've had, say, a Roux-en-Y gastric bypass are more likely to have a dumping type of syndrome, or these individuals might have malabsorptive disease leading to diarrhea. If you've had a patient who's had a resection of their terminal ileum, then they might have some difficulty absorbing nutrients as well, and this in turn can lead to a short gut type of syndrome. And many patients who've had cholecystectomies can experience bile salt diarrhea, where they're excreting the bile salts into their intestinal lumen, and this in turn is causing a watery type of diarrhea. Always think about these features of systemic disease when you're seeing the patient as well. Examination is also really important. I think if you can't do a full detailed systemic examination, at least do a really good general exam and a targeted exam based on the history the patient has provided and what you can see before your eyes. Is this person dehydrated or malnourished? Could they be anemic? Are there any signs of systemic disease like, say, psoriasis or rheumatoid arthritis? These are just some examples, and I know everyone's really busy in clinic, but if you can do this sort of targeted exam, thinking about your differential diagnosis, that can really help make life a lot easier in the long run. Routine investigations are for anemia and dehydration. In GI, we like to check CRP, C-reactive proteins, for luminal inflammation. I don't routinely do an erythrocyte sedimentation rate or an ESR if I'm doing a CRP, because the CRP is more specific for the gut. I will check for thyrotoxicosis in someone who has chronic diarrhea, and we like to check fecal calprotectins, and I'll talk a little bit more about that in detail. We want to exclude infection, and then based on history and exam and initial tests, we might want to do more extensive exams like celiac serology, particularly in someone who is iron deficient or has a history of celiac disease, or an endoscopic evaluation if we're concerned for any other morbid pathology. As I said before, I don't routinely check for gut hormones. I don't routinely do a lactose breath test for lactose intolerance either. I ask the patient to stop drinking dairy and consuming dairy and see if there's an improvement. And if there is, well, you have the diagnosis there. The lactose breath test isn't going to add anything extra. And many of us in the States do a hydrogen breath test for bacterial overgrowth syndrome if we think someone has bacterial overgrowth and would benefit from a course of antibiotics. And this is mostly to prevent irresponsible use of antibiotics. Now, fecal calprotectin is an acute phase protein which is present in leukocytes, and what happens is that when there's inflammation of the gut mucosa, there is increased permeability of the intestine. And so these neutrophils, or the granulocytes and monocytes, will migrate into the lumen of the gut. And what happens then is that they take that fecal calprotectin, which is inside them as well. The luminal bacteria then stimulate the release of this calprotectin into the stool. The calprotectin is actually very stable at varying pHs, and you only need a small amount of stool to do an ELISA test to check the level of fecal calprotectin, and we usually use a cutoff of 200 and above to suggest inflammation. There are other tests you can do for assessing intestinal inflammation. So we talked about the CRP, and we talked about fecal calprotectin. There's also something called a stool lactoferrin, which I think the pediatricians often use a bit more than the adult gastroenterologists. And but what has been shown in multiple studies is that the fecal calprotectin is very more diagnostic in a pooled odds ratio of 19 compared to 11 for CRP and 16 for stool lactoferrin when we're trying to exclude inflammatory bowel disease. And especially for ulcerative colitis, it has an even higher pooled odds ratio of 28. There are various indications to refer someone to a gastroenterologist, and the main indications really are the presence of alarm features like being older than 50, having consistently bloody stool, being physically unwell, having nocturnal symptoms, abnormal blood tests, particularly being anemic or having raised inflammatory markers, and a family history of either inflammatory bowel disease, colorectal cancer, or precancerous polyps. Also, if someone has an inconclusive diagnosis after the initial evaluation or they fail to respond to an empiric therapy, then you should think about this as well. We only say someone has functional bowel disease if we've excluded the underlying organic disease. IBS, based on the Rome criteria, is a diagnosis that's made if someone has recurrent abdominal pain for 3 days a month in the last 3 months, or if with a change in their stool frequency or form, but the symptoms do improve with defecation. Functional diarrhea is when they have the first two symptoms, but they don't have, they have the last two symptoms, they do not have symptoms of abdominal pain. Now, I just want to talk about the non-infectious colitides. There are 3 main types of colitis we think about in non-infectious colitides. This is ulcerative colitis, Crohn's disease, and microscopic colitis. And there are some individuals who have an indeterminate type of colitis. So they have features of either ulcerative colitis or Crohn's disease. Usually the management is that of ulcerative colitis, and over time they usually will declare themselves either being more of an UC type of picture or more of a Crohn's disease type of picture. There are other reasons to have non-infectious colitis, such as drug-induced colitis. You can have ischemic colitis. I mentioned it's commoner in older people, but also you can have this in, say, marathon runners. This is usually due to a watershed area at the splenic flexure, which causes a breakdown of the mucosa in that area when someone is dehydrated or their blood pressure drops. I'm going to talk a little bit more about graft versus host disease colitis and also about immune checkpoint inhibitor colitis. So before I go any further, I'm just going to talk a little bit about inflammatory bowel diseases. Can everyone hear me at the back? Great, thanks. So inflammatory bowel disease is really a complex disease, and there's no one reason for it, but it's generally thought to be due to an exaggerated host immune response to a variety of environmental factors in individuals who are genetically susceptible. And while smoking is well recognized as causing an exacerbation of Crohn's disease and relatively protective for ulcerative colitis, there's a lot of work going into how the diet, microbiome, and vitamins like vitamin D may be affecting inflammatory bowel disease. We also know that breastfeeding and having a prior appendicectomy or poor sanitation are actually protective factors for inflammatory bowel disease. Now, one of the reasons why there really isn't a proper cure for all of ulcerative colitis right now is because there are multiple pathways that are causing inflammation in the lining of the colon, causing us to move from this normal-looking colonic mucosa with nice goblet cells to this inflamed-looking colitic mucosa where you have an absence of goblet cells and mucin. You have these crypt abscesses and reduction of and an increased neutrophilic infiltrate. And so this can be due to inflammation, which is associated with the mesenchyme. You could have impaired resolution of inflammation. You could have dysbiosis playing a role. The mucosal barrier may be impaired. There may be epithelial dysfunction. And there's really no one drug that covers all of these things and is still tolerable to humans. So that is why these diseases are quite difficult to treat and there's no proper cure for them yet. However, the reason you're all here today and why I'm giving this talk is that inflammatory bowel disease is actually increasing in Asia, particularly in South Asia as well. This is a recent global trend study looking at the evolving trends of inflammatory bowel disease across the globe. And you can see the highest increase in incidence is in Asia. And then when you look at the individual regions of Asia, you'll see that South Asia and the Far East are the two regions which have the highest increase in incidence. So this is a really pertinent problem. I'm speaking to colleagues. I know that there's been an increased incidence in Sri Lanka as well. And this is something that with an increase in Western diet, an increase in other lifestyle factors that may be triggering inflammation in the colon, we will be seeing more and more of. This is a study actually from the Central Province. It was, I think this Dr. Kalabuola's group did this particular study where they looked at the prevalence of inflammatory bowel disease in the Central Province. And what they found was that the bulk of patients were ulcerative colitic patients with a lesser number of Crohn's disease patients. So less than half of the patients who they had in that cohort were Crohn's patients compared to UC patients. The patients with Crohn's disease were younger at the time of diagnosis, roughly about 31 to 32 years, and those with ulcerative colitis were 41 to 42 years in age. It's possible that the younger age of diagnosis for the Crohn's disease patients might also be related to the fact that these individuals might have been sicker and so may have even presented earlier. This is a study that my group did in the States, and IBD is not just increasing in South Asians in Asia, but also when they emigrate abroad, particularly to Western countries. This has been shown in the UK, and we did a study looking at IBD among South Asians in the US, and this was a large retrospective case-control cohort of South Asians with IBD. The majority of these patients who had ulcerative colitis and Crohn's disease were actually first generation. They had no family history of, or a lesser degree of a family history of IBD compared to their white age and gender matched controls, both for Crohn's disease and in ulcerative colitis. There was no significant difference between the two. But what was interesting was these South Asian patients were more likely to have more extensive disease, so they were less likely to have just ulcerative proctitis, so they were sicker patients. As for Crohn's disease patients, they were also more likely to have penetrating disease, so disease that can cause abscess or fistulas, which is considered more severe. I just want to remind you all of what a normal colonoscopy looks like, because we're going to start looking at some abnormal colonoscopies from now on. So let's talk about ulcerative colitis. This is a chronic inflammatory condition which causes remitting and relapsing episodes of inflammation, which is limited, however, to the mucosal layer of the colon. The disease generally starts in the rectum and it extends proximally, and we grade it based on the extent. So you can have disease that is just limited to the rectum, which is proctitis. This is up to the last 18 centimeters. It can go up to the left colon, just below the splenic flexure. This is proctosigmoiditis, and then when it reaches up to the splenic flexure, it's called distal colitis. Extensive colitis is when it goes beyond the splenic flexure but stops without affecting the right colon, and then you have pancolitis. These patients often present with hematochezia, so bloody stools and urgency, and when we examine the patients, we tend to do a colonoscopy or a sigmoidoscopy based on severity and take biopsies. The colonoscopic or endoscopic appearance is graded using the Mayo criteria. So Mayo 1 is mild disease, where with the normal colon, you can see the vasculature. There's no edema. Here you start seeing a reduction in the vasculature and edema. Then as you go to Mayo 2, it becomes more, that erythema and congestion becomes more prominent. You have some granularity. It becomes more friable when you put the scope in, so they might have some contact bleeding. And then Mayo 3 is when you have really severe colitis, a really, really sick colon where there's spontaneous bleeding and ulceration. Many patients, so about 40% of patients with IBD, also have at least one extraintestinal manifestation. And I'm going to just highlight some of these ones that we see. So a general exam is also really important. This is pyoderma gangrenosum, where you have that non-healing violaceous ulcer. Patients with ulcerative colitis are more likely to have basal cell skin cancer at the time of diagnosis. So that's also something to be aware of. You can often have autoimmune eye disease, such as uveitis, as shown here, and erythema nodosum, where you get these painful nodules on the shins. Ulcerative colitis patients can often have concomitant ankylosing spondylitis, and this is the classic, bamboo spine appearance that we can see on X-ray, and also they can have sacroiliitis as well. About 3/4 of patients with extraintestinal manifestations actually develop this after their IBD diagnosis, but about 1/4 can develop their extraintestinal manifestations up to 2 years before their actual diagnosis of IBD is made. And for many of these patients, there are certain extraintestinal manifestations that actually can mimic or parallel what's going on inside their colon. So, for example, if you have episcleritis or oral aphthous ulcers, then it may be that the intestinal lumen is also starting to get more inflamed. So a patient who you see in clinic who has ulcerative colitis may not yet have diarrhea, but they may be starting to complain of mouth sores, and this may actually be a harbinger of what is to come. There are other extraintestinal manifestations, such as axial arthropathy, so the ankylosing spondylitis arthropathy, or peripheral arthropathy, which may not necessarily parallel the inflammatory course of colitis, and so those patients can flare in their joints, but their colitis can be well controlled. But it's just good to have some idea of that. We want to exclude infection at diagnosis, and one of the things that can trigger a flare of ulcerative colitis or an exacerbation is cytomegalovirus. So we try to do at least a sigmoidoscopy and take some biopsies. Non-invasive X-rays are helpful if someone has severe abdominal pain. Edema of the bowel wall can give this classical appearance of thumbprinting, or in very severe cases, you can get toxic megacolon, which is something that we're trying to avoid because it's an indication for a colectomy. We want to assess the severity by checking for anemia, checking the inflammatory markers. We also like to check a serum albumin, not because it's a marker of nutrition, it's not, but it tells us if the albumin level is low, then someone has a leaky gut, and this is someone who's sicker because they have more inflammation. And so in that situation, you might need to give them more aggressive therapy as first-line treatment. And then if someone has severe colitis, you may plan to do a colonoscopy when you go in, but if the colitis is very severe, we do not do a full colonoscopy. We just stop at a sigmoidoscopy and take biopsies, because otherwise there's a significant risk of developing a perforation, and this is present in all the guidelines, both in the US, the UK, Australia, and Europe. And then we treat based on disease severity. So when we talk about disease severity, the old criteria just looked at clinical features. So they looked at, the frequency of defecation and graded it as mild, moderate, and severe. But the new criteria, which came out in 2020, actually looks at other poorer prognostic features and helps us gauge treatment based on that. So if someone is younger at the time of diagnosis, so if they're less than the age of 40, if they have extensive colitis, like I showed in my previous picture, if they have Mayo Score 3 disease, or they've been hospitalized for their colitis, needing either intravenous fluids or steroids, if they have very high inflammatory markers, and I talked about the low serum albumin, these are really poorer prognostic features and carry a worse prognosis with a higher risk of colectomy. So these are people you need to really keep a close eye on, maybe admit them, and make sure that they start to respond to treatment before you send them home. The treatment for ulcerative colitis, I'm just going to talk about medical treatment, is graded based on whether someone has mild to moderate disease or moderate to severe disease. The 5-aminosalicylic acid agents are the bread and butter of treatment of mild to moderate disease. If someone has joint pains, we can give them sulfasalazine as well. These are usually tablets, or you can have enema or rectal preparations. And then when someone has more moderate to severe disease, we consider the anti-TNF agents, tumor necrosis factor agents. We can think of immunomodulators like azathioprine, or some of these newer agents like that target the IL-12, IL-23 pathway, the synuclein 1 phosphate modulators, or the JAK inhibitors. And I'm not going to talk too much about this. I just wanted you to be aware of what we're doing and what's to come in the future. There really is no role for probiotics, and in the past we used to give antibiotics when people were flaring with UC. We don't do that now unless they're really sick and they have features of infection. We do give steroids, oral steroids initially until these other medications kick in, or if someone's really sick, they'll have intravenous steroids. And there's a lot of work now going into how diet, stress, and poor sleep can aggravate flares, and how we need to look at patients more holistically and try and adapt better methods to improve their symptoms. There are lots of really complex pathways involved in treating inflammatory bowel disease, and a lot of the drugs that we use cause broad suppression of pro-inflammatory effects, so these patients can often end up being very immunosuppressed. But the newer drugs are more targeted. They act on neutrophil recruitment and T helper cell induction, so they're less likely to cause immunosuppression. And the other advantage is a lot of these newer drugs that are in the pipeline for ulcerative colitis and Crohn's disease are oral agents. So the bread and butter of 5-ASA, of UC treatment, is with 5-ASAs. If someone has more distal disease, we tend to treat them with rectal preparations. So with proctitis, we'll give them suppositories. With left-sided disease, we'll give them foam enemas. Or if they have pancolitis or extensive colitis, we will give them oral mesalamine. Sometimes you have to give a combination of both. By and large, the 5-ASA drugs are considered to be relatively benign. They've been around for about 80 years, but I've had patients come to me with alopecia because of the 5-ASA drugs. They can get headaches, they can get abdominal cramping, worsening of diarrhea. Tubular interstitial nephritis is a very rare complication. They can have hematological abnormalities like thrombocytopenia, which can cause purpura. And I have seen a few cases in my practice of interstitial pneumonitis caused by 5-ASAs, which resolved after discontinuing the drug. We try to avoid prolonged corticosteroid use. It's not a maintenance treatment for this condition because you can get various side effects. This is an example of, does anyone know what this is? Yes, this is bilateral avascular necrosis, where you see narrowing of the joint space, and you can see flattening of the femoral head, both on X-ray and also on MRI. This is just a systematic review which shows that opportunistic infection is one of the main side effects of prolonged corticosteroid use. So really, if someone keeps on needing multiple courses of steroids, you need to really think of putting them on a steroid-sparing agent like an anti-TNF agent or azathioprine. Nowadays, we're moving towards oral budesonide, which is a different type of corticosteroid which has less systemic side effects. And this is because once ingested, it undergoes extensive first-pass metabolism in the liver. So the amount of steroid that actually reaches the general circulation is less, and patients have less steroid-induced side effects. Immunomodulators like azathioprine are still used. We don't use methotrexate for UC after a MERIT UC trial data, which was published a few years ago. And there are some new agents, as I mentioned, that are used for the treatment of UC. Now, moving on to anti-TNFs, I know you use it a lot here in Candy. The anti-TNFs which are available here are infliximab, adalimumab, and golimumab, and they're licensed for moderate to severe ulcerative colitis. Nowadays, the school of thought is to give infliximab rather than adalimumab for patients with ulcerative colitis, because multiple studies have shown that patients who are on infliximab are less likely to lose response or less likely to require dose escalation and have greater clinical benefit if they have ulcerative colitis than those who are started on adalimumab. Because these drugs cause potent immunosuppression, you need to exclude infection. So TB is something that we are really rigorous about excluding. We tend to use the T-spot or the TB quantiferon test rather than the MANTU test, because very often these patients have been on steroids, and that can actually lead to a false negative MANTU result. You want to vaccinate these patients. Once you start an anti-TNF, you really can't give them live vaccines because there's a risk of developing infection. So we make sure that they have their flu vaccine, their pneumonia vaccine, and now the COVID vaccine as well before starting their anti-TNF. We also, in all ages, not just individuals who are over the age of 50, we recommend that they have an inactive shingles vaccine, so the zoster vaccine. Once you start the anti-TNFs, we make sure that they keep up these annual flu vaccines up to date. They are at a higher risk of melanomas, so we make sure they have an annual skin check and use a good sun protectant factor, even if they have brown skin such as ourselves. Rarely lymphomas, hepatitis, and neuropathy or demyelinating disease can occur. Also, the other thing to think about in older patients, because even if you think about our cohorts that I talked about, you are seeing older patients here. Congestive cardiac failure is a rare complication. So these patients, if you do have an older patient who has potential risk factors for congestive cardiac failure, you should be doing an echo before starting them on this medication. Now, moving on to Crohn's disease. So Crohn's disease is, unlike ulcerative colitis, which is just limited to the colon, it's a disease that can affect you anywhere from the mouth all the way down to the anus. This is a really severe disease phenotype. Patients often present with weight loss or abdominal pain, particularly if the small intestine is involved. They can be anemic. If they have more colonic disease, then they're more likely to have diarrhea. In Sri Lanka, we talked about how it's a younger age of onset than ulcerative colitis and a shorter time to diagnosis. Now, there are various phenotypes of Crohn's disease. You can have just inflammation, or you can have stricturing disease, which can lead to cramps, distension, and vomiting, particularly if it's in the small bowel. They can have penetrating disease, and depending on the location of these fistulas forming, because it's the ulcers that form in Crohn's disease are very deep ulcers, and they can penetrate through the bowel wall. And so if you can have an enteroenteric fistula, which can cause symptoms of weight loss or diarrhea, you could have an entrovesicular fistula, which causes hair or feces in the urine, or enterocutaneous fistulas, where you have non-healing wounds either in the perianal region or in the abdominal region. This is what the endoscopy of or colonoscopy of a patient with Crohn's disease looks like. With both ulcerative colitis and Crohn's disease, when we're trying to do a colonoscopy, we try to go all the way into the terminal ileum to make sure that there's no small intestinal disease. The Crohn's inflammation can start off with these little discrete aphthous ulcers, so a bit different from what you saw with the ulcerative colitis. They can get these linear ulcers and then these very deep ulcers, and then over time they get this classic cobblestone appearance, which is due to these fissuring and ulceration with these separate islands which pop up. This is, and this is just what the histology looks like. You can see here you have these fissuring ulcers which extend deeply and almost through to the muscularis, and you have increased lymphocyte aggregation here. The other thing is, like in the books, we're told that Crohn's granulomas are pathognomic for disease activity. Here you can see a pericrypt granuloma. However, only about 30% of patients with Crohn's disease actually have these granulomas on biopsy. So you do need to take the full clinical picture into account. Now, when we think about Crohn's disease therapy, it's somewhat similar to ulcerative colitis. Really, the change, as my surgical colleagues will tell you, is when you're thinking about surgery for Crohn's or ulcerative colitis. But moderate to severe disease is often treated very similarly to moderate to severe ulcerative colitis. The caveat being is that adalimumab or Humira is as effective as infliximab, in the treatment of Crohn's disease, unlike in ulcerative colitis. Again, we will give patients steroids for a limited period of time. There is a school of thought that there is an alteration in the microbiome that really promotes inflammation in Crohn's disease. So there may be a role for antibiotics. And certainly before all of these drugs started, when Crohn's disease was first described about 80 years ago, antibiotics were the mainstay of treatment for Crohn's disease. In the pediatric population, and we try with the adults to, particularly if there's small bowel disease, to give them some bowel rest. Children are much better than this. Adults can be very stubborn. But if you can give someone complete bowel rest, particularly if there's small intestinal Crohn's disease, you can actually rest the gut and allow that mucosal to heal. And this has been shown in multiple studies, particularly in the pediatric literature, as I'm sure my colleagues will say. And then with the mild to moderate disease, this is where the problem is. We used to give mesalamine, the 5-aminosalicylic acid drugs for this, but multiple studies have shown that it's not that effective for Crohn's disease. So what treatment options do we have? We don't really have a lot. It's a real area of need. We talked about dietary modifications, and there are some other new drugs that potentially might be coming out on the market in the next year or two, which are targeting this, because sometimes it's really difficult. If someone just has a very small aphthous ulcer, like I mentioned before, you obviously don't want the disease to progress, but can you really justify putting them on an anti-TNF? And that's where these things like diet and environmental factors may play a greater role. So I just want to present a case. This is a 42-year-old woman who presents with a 6-week history of intermittent bloody diarrhea, a dry cough, abdominal pain, and weight loss with night sweats. She's not started any new medications, and she has no significant past medical history. On exam, she has a BMI of 17, is pale and unwell looking, has a mild fever, and a tender right lower quadrant. Any idea what you'd like to do here as first-line investigation? So we decided to do a CT because she was having a painful tender right lower quadrant. We didn't want to stick a scope in straight away. And what we saw was that she had this short segment of ileocecal thickening here and a necrotic lymph node. We then went on to do a colonoscopy, and she generally had a normal looking colon. The ileocecal valve was quite patulous, and then going into the terminal ileum and after taking biopsies, we saw this blunting of villi with branching of the crypts, and also a necrotizing epithelioid granuloma. And here you can see this granuloma again with central necrosis. Any ideas of what this may be? Any of the junior doctors? TB? Yes, so well done. So this is intestinal TB, and Crohn's disease can often mimic intestinal TB. The symptoms are very similar, but patients with Crohn's generally have a longer symptom duration compared to those with intestinal TB. They tend to more likely have hematochezia or perianal disease and more likely to have extra intestinal manifestations, whereas with TB, they tend to have more history of night sweats and may have, in advanced cases, lung involvement or ascites as well. Imaging and colonoscopy for Crohn's shows more extensive involvement, so they can have long segment or left colonic involvement and skip lesions and cobblestone appearance, and the classic Coombs sign, which is due to mesenteric edema, or comb sign, where it looks like mesentery looks like a comb near that area of inflammation. Whereas with intestinal TB, there's very limited ileocecal involvement, and lymph nodes are more prominent, and you can see this patulous ileocecal valve. Moving on to our next case. This is a 68-year-old female who presented to clinic with a 3-month history of chronic watery explosive stools. She has occasional abdominal cramping and denies hematochezia and no weight loss. She feels thirsty. She's a type 2 diabetic on metformin, also has gastritis on omeprazole. HbA1c is pretty good. She's a bit hypokalemic, probably because of her diarrhea. Any ideas of what you'd like to do for your further workup? So in the interest of time, we did stool studies, and she had a borderline high calprotectin. We did a colonoscopy. It looked normal. So this, we did take biopsies, however, and what the biopsies showed was that this is microscopic colitis. This is commoner in older females with profuse watery diarrhea, which is non-bloody, and they often have urgency with weight loss and fatigue. The colonoscopy is always normal or near normal, and they can either have profuse lymphocytic infiltrate on biopsy, which is lymphocytic colitis, or this layer of collagen at the mucosa and submucosal level, which is collagenous colitis. Many drugs such as these have been linked, and our patient was on a PPI. Initially, a lot of these patients were misdiagnosed as having irritable bowel syndrome, and there is actually a link between celiac disease and other autoimmune diseases like Crohn's disease in some of these individuals. The treatment goal is really to reduce their stool frequency and give them a better quality of life. We tend to give them anti-motility agents like loperamide. We can also give them that oral budesonide, which has less absorption, so less likely to cause osteoporosis. Cholestyramine, a bile salt supplement, has been shown to be effective, as has bismuth salicylate, but you do have to be careful about bismuth or Pepto-Bismol because over time this can accumulate in the body. We don't yet know what the role is of probiotics, and I have had refractory patients who keep on requiring multiple courses of budesonide who have had to start on either azathioprine or anti-TNF, but then had very good results. And this is some data from Base Hospital Parnadura, where they looked at a cohort of 200 patients who had presented with diarrheal stool, and found that 29 of these individuals had microscopic colitis. It was interesting that the male to female incidence was the same, and they were a much younger group. They were about 35 years of mean age and had very IBS type symptoms. So this is something that you're all seeing. This next case is a 41-year-old female who had an allogenic stem cell transplant 3 months ago for a lymphoma. She now presents to clinic with watery diarrhea, 3 weeks duration. She's had no hematochezia or anal bleeding, and her stool studies for infection are negative. We went on to do a colonoscopy and biopsy on this individual, and what we found was that she had these isolated ulcers with surrounding congestion. Any guess as to what this might be? This is graft versus host disease. So, and what we saw on the biopsies were the presence of these apoptotic bodies. So I know that there's a big drive to do stem cell transplant in Sri Lanka, but there are also other patients who are going abroad and getting these stem cell transplants now. Graft versus host disease of the colon is common. Classically, acute graft versus host disease was considered to occur about 45 days after transplant. Now we say it's less than 100 days, and it's commoner in patients who have had allogenic transplants. Interestingly, it's less common in children who've had stem cell transplants. And we don't yet know why. These patients can get really sick. They have profuse diarrhea of more than 1.5 liters a day, with a lot of mucosal ulceration and bleeding, and it's a rich mucoid diarrhea, often associated with abdominal pain. The treatment is with steroids, and they may need other immunosuppressive therapies as well. Immune checkpoint inhibitor colitis is something I just wanted to touch upon. Immune checkpoint inhibitors are the new kids on the block when we talk about treatment of cancer. These medicines, what they do is they help the body to recognize cancer cells by acting on these CTLA4 and PD-1 receptors. They were first used for skin cancer, particularly melanomas, but are now used more widely in other cancers, such as renal cancer and lung cancer in particular. But colitis is actually a very common complication of these treatments. The median onset usually is about 6 to 8 weeks after initiation of treatment. They often have watery stools with mild to moderate abdominal pain. We want to do a colonoscopy in these patients, usually a full colonoscopy. The endoscopic appearance is not really that specific. They can have some redness, some edema, some friability, superficial ulcerations, and erosions. So you really do need to take a biopsy and exclude CMV, and also look for classic features of ICI colitis. And the therapy, again, even though these are immunosuppressed patients, they do need to have steroids and potentially other immunosuppressants like anti-TNFs as well. So to summarize today's talk, we discussed the differential diagnosis and alarm features when investigating for chronic diarrhea. We talked a little bit about the various drugs commonly used that can cause diarrhea. UC and Crohn's disease are prevalent in Sri Lanka, and the incidence is increasing. So do think about this when you're seeing your patients for various other conditions, if they have chronic GI symptoms as well. And we talked about how to investigate and treat UC appropriately based on disease severity and how to ensure that health maintenance is adhered to properly, and also the pitfalls of prolonged corticosteroids. And just think about these other potential inflammatory colitides as time goes by. So thank you very much for your attention, and I'd be happy to answer any questions.
The forum is open.
Any questions from the online audience?
No. Thank you very much for the excellent talk. So I do have few comments and questions. So comments are that she has nicely elaborated the importance of doing the fecal calprotectin in our setup, which we can do. Unfortunately, we can't do the calprotectin test in our setup, but there was one lab who was doing the calprotectin lab, but unfortunately it was very expensive. So we can't do it in our setup at the moment. So, and the other thing, she has nicely described that when to refer for further investigation. So, I mean, a lot of things we can do in our, in the basic setup that before we refer for the further investigation, especially for the colonoscopy, because we all know that with the available facilities, we can't give an early date for colonoscopy because I mean, there's huge burden to the gastroenterologist unit if we ask for the not relevant cases. And my question is, so are there any evidence to use probiotic in IBD associated diarrhea? And the second question is that are there any place for vitamin supplement like vitamin D and zinc supplement, especially in the IBD associated diarrhea?
Yeah, thank you for that question. So I'll answer the first part first. So probiotics, not yet. The reason being is that we don't have any good studies that have examined the role of probiotics in inflammatory bowel disease. The studies that have been done are usually not randomized controlled clinical trials, and in addition, they're usually sponsored by the probiotic company. There was one probiotic called VSL3, which was shown to be effective in patients who'd had pouch surgery, and it helped to prevent pouchitis. Multiple other investigators tried to repeat that study and didn't get the same results, and that study was actually funded by the VSL3 company. So patients will use probiotics. In the States, practically everyone's on a probiotic. So I just tell patients you can try it and see if you like, if you feel it helps. It's not going to cause any harm, but I don't know if it's causing any good. And patients will often ask me, which probiotic should I take? I just say take the cheapest one. There is some role. I do tell them, I don't, not just that, but I do tell them to, there are studies that have shown that lactobacillus, Saccharomyces are beneficial to the gut and create a healthy environment. So if patients tolerate those, they can take them. But it's not a cure for ulcerative colitis. It may just create a more sustainable gut environment, but not necessarily reduce inflammation. And then your other question about vitamin D and zinc, I think that's a really important question. Many of these patients are deficient in vitamin D. Patients who have chronic inflammation of the gut have vitamin D deficiency, and so it is really important, if you can, to check a vitamin D level and start them on a vitamin D supplement if they're deficient. But if you don't, if you can't check a vitamin D level, you can still ask them to check a vitamin to start a vitamin D supplement. I don't give very high dose vitamin Ds unless someone is really deficient. The other thing is that in terms of that, the vitamin D that you give the patient, there have been studies which have shown that there are vitamin D receptors in the gut. So having a low vitamin D level could actually promote inflammation. So there are two reasons to give someone vitamin D: to reduce that inflammatory pathway and also to help supplement their vitamin D levels. These patients are more prone to malabsorption and osteoporosis, so that's another reason to protect their bones. And you may say, well, I live in Sri Lanka, I get plenty of sunshine, although you wouldn't think that right now, but the vitamin D pathways, as you know, are different, and so intestinal vitamin D is different from the vitamin D we get from sunshine. And then zinc, I don't routinely give zinc supplements, but there is some, if someone's really sick, if they're malnourished, then or they have features of malnourishment, particularly with Crohn's disease patients, I will check a zinc level, and if it's low, I might give them a zinc supplement.
You mentioned about screening for TB before starting anti-DNA. Do you suggest doing histologic colonoscopy and histologic samples to be checked for TB, or is just the PCR?
No, we don't do that. We just check. We used to do the Manto test, but then there was a paper that came out about 10 years ago, which suggested that, which showed that there was less sensitivity and specificity of the Manto test in individuals who had inflammatory bowel disease, particularly because they'd started steroids prior to starting the Manto test. Because in the West, these diseases are more common, so a lot of the general practitioners feel comfortable giving a course of prednisone for someone if they think they have ulcerative colitis after they've done initial screening for infection. And even in the gastroenterology clinic, if a patient has a first presentation with, say, ulcerative colitis and it's diagnosed, before you can get all the anti-TNFs approved and these patients started on these medications, it takes time, and these people are suffering, so you have to do something for them, and so very often they're given steroids in the interim. So again, and that can blunt that response. So, but we don't do a colonoscopy for biopsies. I brought up the Crohn's intestinal TB because it's very common in India, as you know. I think less common here, but I think it's something to think about. And we are seeing a rise in intestinal TB in the West due to the increase in HIV.
Isn't ESR a better investigation to assess chronic inflammation? You said ESR you don't do, but you do CRP.
ESR is a better test to check for chronic inflammation overall in the body, so systemic inflammation, but the C-reactive protein is more sensitive to or specific for gut inflammation. So we go by the CRP rather than the ESR, because you could have, say, joint arthritis and no luminal inflammation, and your ESR could be high. But the CRP really goes up when there's gut inflammation, more so than ESR. I know there's a big difference in cost though between the two, so that's something to think about. We don't routinely check for procalcitonin. There have been some studies which have looked at that, but it's a very expensive test over there. We don't do it.
It's expensive there. It's expensive here.
I think the only people I've seen use it are the doctors in the SICU and the medical ICU.
So we are not very different from US then.
There are more similarities than differences, I think.
Vitamin D levels is so big. I know.
Yeah.
Before the dollar debacle, it was 18,000.
Yeah. I think, I'm not advocating that you routinely check for vitamin D levels, obviously given the resources, but I think it's important to make sure that if you are concerned about the patient, if they look malnourished, if there's a history of weight loss, if they're still having a lot of diarrhea or abdominal pain, then I think that it's worthwhile starting them on a vitamin D supplement, but I wouldn't rush to give them, like, say, 50,000 units a week, which is a high-dose vitamin D supplement. In that patient, I would probably check a level first, but by and large, I tell all my patients when I see them in clinic, we routinely have to take a vitamin D level because it's in our guidelines, but I tell all my patients to take a low-dose vitamin D supplement, particularly the older females.
And we talked about bowel resting. So
Yes.
is that starving?
Yeah, so bowel resting is essentially the patient doesn't eat or drink anything with some normal food for usually a period of 6 weeks. And instead, So there are two things you could do. You can either give total parenteral nutrition, but the pediatric literature, so they get the nutrition through TPN, but the pediatric literature has actually shown tremendous success with using exclusive enteral nutrition. So these are these polypeptide solutions like Peptamen and other, ensures, which are easier for patients to absorb because their polypeptide compounds are not big proteins, and so it allows the mucosa to heal. And there have been several studies that have shown this benefit with repeat colonoscopies and biopsies, which have shown significant improvement. It's actually the mainstay of treatment for Crohn's disease. Exclusive enteral nutrition with these oral supplements is the mainstay of treatment for Crohn's disease in pediatric patients.
So in Sri Lanka, our experience regarding pediatrics, more than the bowel rest, we use the elemental diet more than that. And so we don't, in Western countries, the pharmacy prepares and gives the elemental diet.
Yeah.
But here we sort of get the formulas and we sort of tailor make it to the patient as needed.
And I think that's perfectly fine. We actually do that for the adult patients because it's very difficult. Elemental formulas are very poorly tolerated as well. They taste terrible. And so children don't like them, adults like them even less. And so ensures or these other formulas are better tolerated. That's exactly what we will do.
This question on colonoscopy. So I'm not sure if this is a repetition of the question that was asked earlier, but if there is a first presentation of the patient, suspect IBD, most likely Crohn's, see the lesions, in our population, given the incidence of intestinal TB as well, and without the diagnosis, at the time of colonoscopy and biopsy, would you send samples for TB-PCR as well?
We don't routinely do that, but what we do is both for ulcerative colitis and Crohn's disease, we take biopsies from throughout the colon and the terminal ileum as well. So we do segmental biopsies. I think if there's a very strong suspicion for intestinal TB, then you can do that. There's nothing to say that you shouldn't. We just don't do that routinely because we see less intestinal TB right now at that degree. But certainly, and most of our pathologists, whenever I've sent specimens to the pathologist, they'll usually do a H&E stain and then if there's a suspicion, clinical suspicion, then they'll check for AFB as well.